Welcome to Your Infinite Health. Are you getting older?
Are you feeling it?
How would you like to do that in reverse?
We're your host,
Dr. Tripp
and LeNae.
We've run an integrative medicine practice for 13 years.
Together, we have 60 years of combined experience helping clients.
We've helped tens of thousands achieve success in health and live longer, happier lives.
In this show, we'll cover peer-reviewed and evidence-based integrative approaches to creating the health you've always wanted.
We also share professional experience we see in the field every day.
So if you're ready to feel, look, and live your best life, you're in the right place.
Welcome to Your Infinite Health podcast.
Today was Huckleberry's student-led conference day. Back when I went to school, it was called Parent-Teacher Day, and it was not necessarily a positive experience. Here, it's the student that creates the presentation. I mean, that kid had a 16 slide, a slide deck. A slide deck with 16 slides. Talked about his goals and how he's improved from last semester to this semester and what he's looking forward to. Like, it was quite the professional little presentation.
So for an 8th grader, really quite advanced, I think.
Yeah, so that's cool. I think that'll set him up for success in any business because he'll learn communication and, giving information in a sequential manner that makes a modicum of sense, hopefully, and the ability to speak to a group.
Yeah, it would have been harder to do that in my day, chalkboards and all.
Yeah, back in the day of chalkboards. So we did that this morning. We had a good family breakfast over there at the Blue Line. Love that place. In a little bit, be taking Henry over to music. It's not really music lessons anymore, to his recording studio. He's working on his album. So that's kind of what we have got going on. And those two kids in the back seat are cracking me up. They were doing some ridiculous banter between the two of them, just kind of being snarky back and forth. And I pulled out my phone to record it. And as soon as they saw the phone, they were like the whole thing shifted. And I hit record anyway. And by the end of it, they were pleading for people to save them from the basement and asking for donations to a GoFundMe page. So that was kind of a fail, but I posted it anyway if anybody's interested in what happens when I drive my two kids around at the same time. That's what is going on. And then the other day, Henry accused me of stealing his thesaurus. I didn't even know he had a thesaurus. So he accused me of stealing it. And not only was I shocked, but I was appalled, aghast, and dismayed. That was a joke, people. The kid does not have a thesaurus. That being said, so we don't have a guest today, but I thought since Infinite Health is running a promotion right now where someone can they're saving like over $750 on a Prolotherapy service for knees in particularly. So I thought you could talk about knee pain, the knee pain that you've experienced, that your patients have experienced, how you've treated that knee pain and the kind of results that you've gotten. Because I don't think a lot of people are still aware that surgery is not the only option. So you want to talk about that today?
Sure. I think surgery it has historically been the option and is in the United States is a highly utilized option given the advent of arthroscopic surgery and those things, using scopes and not having to do open, really wide open procedures. But those same procedures, the number of procedures in the United States in about 5-6 years ago was the most frequent procedure performed in the United States. And
knee surgeries were the most frequent surgeries?
Arthroscopic knee surgery. So arthroscopic surgeries actually, in a large meta-analysis of the outcomes of arthroscopic surgery versus simply the frequency of that surgery being what it is. Been a number of clinical trials comparing the outcomes of arthroscopic surgery in the setting of degenerative disease with less invasive processes, and the least invasive being simple physical therapy. Meta-analysis performed on numerous trials, pulling all the statistics together, actually showed that at 6 months there was a trend for arthroscopic surgery to actually have a little bit better outcome, not significantly, but a trend towards a better outcome. But
over Tracy in Wisconsin, what does arthrosclerotic mean? Is that what is that?
Arthroscopic.
Yeah, that one. What does that mean?
So it's where they take a little scope. It's like a little camera. It's really, really small, and they put it into the joint, and they look around to see the structure of the parts, the anatomic parts inside the joint, and the meniscus and the cartilage and all that, and they trim it and they flush it out, and they do a number of different things in there, and then they close it up. And if there's something necessitates a surgical, like putting things back together, and that they can do that by a scope versus opening the knee up and exposing it to higher risks of infection and things like that.
Okay, continue forth.
So it became so frequent that they wanted to see if it was really giving better outcomes in conservative cases as that didn't need real open surgery. And they found that, like I said, there was a trend towards improved outcomes at 6 months, but in the long term, so at 1 year and longer, there is no difference in outcomes. So it's a procedure that has a utility more so in a more aggressive sense, but in just standard degenerative disease with minor changes or moderate changes, it's probably not warranted and can lead. And subsequent trials have also disclosed that it actually accelerates the degenerative process. So really alternative methodologies, and what I do, for example, with the prolotherapy, have also been evaluated. And there are a number of things for people with degenerative arthritis, a number of treatment strategies, but the ones that actually help the most with pain and recuperation, physical recuperation, are injectates. Historically, the first one was a hyaluronic acid derivative. I guess people may know it more as rooster cone or that. And that injection kind of lubricated the inside of the joint and actually helped mobility in the first couple of injections, but subsequent injections actually became less and less effective. That, and then with the advent of PRP, using prolotherapy and injections of platelet concentrates into the joint, subsequently has been shown in randomized trials work that that's actually better than using the hyaluronic acid derivatives, that in terms of pain relief and in terms of function. So it's kind of been a stepwise improvement that we've noted over the years. And I started when I started doing prolotherapy about 9 years ago, the prolotherapy being different than what typically is used by pain management orthopedic physicians, that it's a sequential injection into the fascia and into the ligaments and tendon insertions around the joint and into the joint itself, into the articulation and into the space where the lubricants and that are usually held. So that process, I've been doing that process for almost a decade now, I guess. And what I've kind of followed this stepwise improvement in outcomes and in products that we can use in the joint and use with prolotherapy for improved outcomes. And at this juncture, we're using umbilical cord derivatives and Wharton's jelly and exosomes and stem cell derivatives, and they are really having phenomenal results. The delay in it being accepted by insurance is unfortunate, but at the same time, as these things get more and more objective evidence of their efficacy or their effectiveness, I'm sure that will come about sometime in the future. at any rate, I mean, it makes me think of a case that I had when I first started out. I first started out using dextrose derivatives, basically different concentrations of dextrose for my prolotherapy injections, and then subsequently with the advent of PRP and learning how to do that, I started using PRP a fair amount, and then started using more of the additives with the growth factors and the stem cell derivatives. But even back with PRP, I recall a case of a farmer's wife that stands out in my mind because when she came in, she had a total knee replacement on one side and had such a bad experience with it, and it had such little pain relief effect, and it had helped function to a certain degree, but the pain was still significant, and so she wasn't really happy with that, and wanted to find an alternative approach, and sought us out. And I did PRP prolotherapy on her contralateral knee, but her functionality had decreased to the point where she had to have significant assistance just to get up one step or two steps to get on her front porch to get to the front door. It was that difficult for her. And by the time she had completed 2 or 3 courses of the prolotherapy with PRP, for example, she was back out helping her husband do all the chores, and they had a beef cattle farm, and so she was doing that work and helping with the hay and climbing up and down vertical ladders. And
that's after you did one knee, and how many sessions?
So she actually was back to that level of functionality after the first prolotherapy with PRP.
On one knee or both knees?
On one knee.
On the knee that she didn't have the replacement on.
Correct. And she was already doing the ladder in the barn and all that, but she wasn't completely pain-free. And it was only after it went to, in the sequence, as I can recall, she had 60 to 70% relief after the first, maybe another 20% after the second, and complete resolution of pain and return of complete functionality after the third. And that was a 9-month period of time. At that time, I've actually shortened my intervals now. I used to give 3 months and observe for 3 months prior to initiating another therapy with PRP, but that's been shortened down, and most of my colleagues actually think that 6 weeks is a better interval to wait, and then retreat if complete resolution of discomfort hasn't occurred.
Can you help somebody who's had a knee replacement in that knee, or is that knee it's too late for that knee?
Well, I mean, if they've had a complete knee replacement, they don't have
a knee.
They don't have bone there on that surface anymore. They have a metal surface. Ooh. And there are different degrees of knee replacement also, because the orthopedic surgeons are doing surfaces to replace cartilage, and so it's not always the complete metal upper and lower component of the knee that's replaced. So there are a number of different options in there now that may be a little less invasive, but that's still quite an invasive procedure. When in reality, I see people regularly that have bone on bone joints and severe pain and deformation of their knee, and with 1 or 2 therapies they have significant relief and are back to significant improvements in their
How is that working if it's function. Bone on bone? Like, what's being repaired?
Well, it's not really bone on bone. Bone on bone is a term that is used because of the radiologic appearance. There are always islands of cartilage and residual cartilage stem cells and bone stem cells that can be stimulated by these injectates that actually then regrow cartilage and regrow bone and those types of things.
That would be beneficial for somebody with arthritis in their knee, or no?
Correct. So degenerative arthritis, post-traumatic arthritis, rheumatoid arthritis. I've treated rheumatoid arthritis and even in the small joints where I've had significant reduction in inflammation and swelling and improved functionality, dramatic results.
And then is there any damage to a knee that like they wouldn't be a candidate for prolotherapy? Like, is there any knee issue that you're like, nope, can't help?
Well, if it's post-traumatic and there are ligaments or tendons that need to be connected again and that type of thing, those people are obviously, that's post-trauma, some athletic issues. But meniscal tears, capsular tears, any partial tendon or ligament tears are still within the purview. In my mind, although there are no large clinical trials, the results I've had anecdotally have been very good. So you look back on the clinical trial work, and since there's not a pharmaceutical support of these things, because these are natural products that come from our bodies. There was a trial with about 100 people in it back in 2015 or 2017 that used 3 concentrates of injection of single injections of PRP. And single injection PRP, platelet-rich plasma, when you get somewhere between 4 to 6 times the concentration of the number of platelets in the blood, then those injections were done on different schedules. There was, in the 3 groups, I believe there was the first group was a single injection and observation. The second group was 2 injections at 2-week intervals. And third was 2-week intervals, 3 injections into the joint. And those are single injections of, I believe it was 6 cc's of concentrated PRP. And each group,
That was the patient's.
Those
that was the patient's blood.
Yes, that's
okay.
PRP is always the patient's blood.
Okay, my bad.
So each one of those groups had successively better outcomes and more durable pain relief and return to function. So really interesting stuff, and far superior. The other clinical trial that I mentioned earlier with the hyaluronic acid derivatives is far inferior outcome to even simple PRP injection.
Should you say different?
And that's not using prolotherapy.
Oh,
so the technique of prolotherapy is then even superior in my mind and in my hands as when opposed to a single injection into the joint.
A single injection into the joint is not prolotherapy. Prolotherapy is the method of saturating the area?
Well, no, it's actually injecting. It's a technique that was started back in the 1930s, 1940s, and injects in those days, based on the geometry of the anatomy, was injections into the ligaments and tendons and into the joint and into the insertions of the meniscus and the tendons for the patella and that. And all of those are injected, and the fascia surrounding the joint are also injected and flooded with at the time, back in the day in the 1940s, there were irritant solutions that actually stimulated a small amount of inflammation that subsequently activated the stem cells in the area to repair. Now we can bypass the irritant solution component and use these biologicals that I've been using for between 5 and 10 years to actually accelerate the repair of our own stem cells of those whatever area of the joint they're injected into.
So what does that look like for somebody who they come in, you give them a muscle relaxer, but you don't put them under.
No, I just give a little anxiolytic and maybe a little Ativan as to make them relax a little bit.
Is that like a Xanax?
Yeah.
Chills them out. So they come in, so they need a driver because they're on that chill out thing.
And depending on the size of the area, it takes anywhere from 20, 30, sometimes up to 45 minutes. Not for a knee, though. Knee is pretty quick.
Well, you're talking about your actual time. So they have to be prepped. You got to sterilize the little area, but it's done in the office. And you numb them, right? You do a numbing thing.
Yes, local anesthesia.
I'm a big proponent of whatever doctor can eliminate the pain the best is the winner. So you numb them up and then you administer the prolotherapy in the knee.
With whichever injectate the patient.
Yeah. And then after you're done, they go home, right?
That's it.
But they can't drive home. Don't be driving home.
Not under the influence.
Yeah, they go home and then, or can they go back to work?
Well, and I have a number of patients come in, they don't do sedation and they go immediately back to work.
And then, but they can't exercise until like what?
Well, they can do light exercise. I mean, they can go back to normal daily activity immediately.
Normal daily activity immediately. No need for physical therapy.
Well, physical therapy sometimes helps.
Okay.
Collaborative therapists are really encouraged in the more difficult cases. I like to use physical therapy, chiropractic, and that. But realistically, that's not necessary because the degree of anti-inflammatory activity by virtue of these injections, it does result in fairly significant pain relief within the first few weeks.
Okay, so they'll start to they'll start to become aware of less pain within 2 to 3 weeks.
Typically what I see, I've had all ranges of response, but typically what I see is some pain relief within 2 to 4 weeks and then a slow progressive improvement over the next 8 to 12 weeks.
And then how long? I mean, I guess that depends on like what their activity level is and
also
the level
depends
of
on which injectate they use too. Prolotherapy with PRP, for example, PRP depends. The effectiveness of the PRP depends on how old the patient is. Because PRP from a youthful 25-year-old will be significantly more effective than if they're 50 years old or 70 years old. The amount of growth factor and cytokines and those things that are acquired by centrifugating the blood and getting the platelets out is much better the younger the person is. So by the time a person is 40, they're producing about half the amount of growth factor in their own blood that they were producing at 25, for example. So, and it goes on like that. So it's kind of a geometrical decline in effective biologics that are obtained from the blood. But and that's why realistically, I really like the fact that we can get to Wharton's jelly, which is a distillate of the distillate from the umbilical cord that really has 300 to 400 times the concentration of all of those growth factors and reparative factors that activate our own stem cells to go back to work. It's much more effective and works much better.
Would you do exosomes in the knee?
Yes, certainly. I think exosomes is kind of probably the best approach, if you will, in that those are the particles that are found inside the stem cells that contain anywhere from 500 to 1,000 growth factors, cytokines, little non-translated or non-transcripted messenger RNAs. All of these little things go to more effectively activate and maintain activation of the stem cells, our local stem cells that we're activating to actually do the repair work wherever they're injected or systemically. Of course, that's the most expensive too.
The most expensive, but not really, right? Because you're going to have like the maintenance, I would imagine, is less than any other of the prior ones, right?
Well, I think the durability of the response that you get from the exosomes is better, and the rapidity of the response is better. So they're going to be more anti-inflammatory biologics and activating and biologically activating biologics for our endogenous stem cells to go back to work, and then that activation has been shown to last anywhere from 6, 9, maybe a little more months after the administration. There's a possibility that it's more effective to the point that maybe there will be need for fewer sessions of injections. But right now, with just the plain Wharton's jelly, without the concentrated exosomes, I have in knees at this point, I have not yet had to do more than 2 sets of injections.
There you have it, listeners. If you're having knee pain, why are you suffering? and don't go get surgery as a first response, right? Should be the last
outcomes,
resort.
That's another thing. Obviously, these injections, when they go in, you await the repair that they do, it doesn't mean you may not need surgery in the future, but it doesn't preclude surgery. So having the injections, these types of injections, you may need surgery anyway, but at the same time, it won't impair a great outcome from surgery if you have to have it, within the confines of the statistics of the surgical outcomes, obviously.
Obviously. Okay, so to recap the perks, you can do it same day and go back to work if that's what you really want to do. Although I'd say don't. Just go home.
The day off.
Take the day off. You deserve it. The other thing I wanted to know, and I thought maybe the listener would benefit from that, is how do they find a qualified, if they're not, for whatever reason, cannot come to you, because obviously you're the best at it and your results are superior to what other people try to get. But if you are not an option for them, what kind of questions should they ask, or how do they find a regenerative medicine provider who's going to get them the results that they want? Like how do they do that?
Well, it's going to be a personal search. They're finding first off, finding a provider of prolotherapy would be the primary objective, I would say. I would not go to someone who does not practice prolotherapy, and because the outcomes are going to be better from the procedures. A single injection may get some results, but they're going to be inferior to a complete and thorough prolotherapy of any joint, quite frankly. So it will depend on how many practitioners of prolotherapy are available in the community that they're in.
Okay, no specific. So the specific question is, does that provider do prolotherapy specifically?
Correct. And then the second question would be to the practitioner is which injectates are they familiar with, which ones are they advising, and or which ones would the individual like. So there may be budget constraints, and there are options at virtually every level. Those are the most important questions. But if you
I would also say, and how long has somebody been doing that, right? You don't want to be the guinea pig for that provider. Don't be the guinea pig. Ask them how many they've done. It's between me and you. I don't think I have any other questions. Oh, the only thing I will say is, because I did have somebody call me and argue with me about the person wanted to get reimbursed from their insurance company for the prolotherapy that they had earlier in the year. And let me just tell you this: no code, no claim. Had to explain it to this person who was arguing with me about what other providers are doing. And I don't know what other providers are doing. What I know here is that we will not bill. There is no code for regenerative procedures for your insurance. Your insurance company doesn't care what you did. They don't count it towards your deductible because there is no code. No code, no claim. No code, no claim. Life lesson. Anyway, I hope you found this educational, informational, somewhat entertaining, and until next time.
Thanks for subscribing to Your Infinite Health. I'm Dr. Tripp.
And I'm LeNae. Until next time, feel it, look it, and live it.